Good morning. You guys aren't very good on call and response. Good morning. My sole and brief job as president of Rice University is to welcome all of you to the university and our Baker Institute for Public Policy. The Baker Institute plays the leading role at Rice in bringing together people from academia, business, government, people in research and policy to examine some of the most important policy issues of our time. It examines issues across a fairly wide spectrum, including energy, science and technology, health policy, health economics, and border issues. Rice's Baker Institute Science and Technology Policy Program and the University of Texas MD Anderson Cancer Center are very pleased to present this program, this yearly program, as part of the Medicine, Research, and Society Policy Issue series. I don't have to tell this audience how important these issues are. Of course, a year and a half ago, we thought they would all be solved by now. But in this more sober environment, we know, as health spending has exceeded 16% of GDP, that these issues are more important than ever, and if we don't find solutions, we will have even bigger problems to deal with. We think there is no better place to deal with them than here in Houston, with all of the remarkable institutions from the Texas Medical Center. And we at Rice are so pleased and grateful that so many of you from the great institutions of the Texas Medical Center are here with us today to participate. It is in that context that it gives me great pleasure to introduce my friend and colleague, a truly remarkable person, who I'm not going to introduce further because his bio is in your program, the president of MD Anderson, John Mendelsohn.
Well, thank you, David. Welcome to the second of our series, the Baker Institute and MD Anderson working together, a series on medicine, research, and social policy. And of course, we picked the date very carefully. This is the date of the President's Summit, which is supposed to bring together two parties who are supposedly governing our country and see if they can get to the task of governing. And what we're going to be talking about today is very relevant to what they're trying to solve. A significant component of the debate, obviously, over and beyond covering insurance, is the quality, value, and escalating cost of health care. And addressing these issues requires knowledge that can be gained through comparative effectiveness research on the outcomes of different therapies, procedures, and care delivery systems. And the body of research that can be collected will impact healthcare and will determine what interventions and procedures and processes work best with various populations and which bring the most benefits and which bring harms. And we have a huge amount of work to do to answer those questions. Now, we have two very distinguished speakers today. I'm going to just briefly introduce them, and then they're going to take over. And afterwards, there'll be questions. And please jot down your thoughts. And we're going to have two microphones, one here and one here, that'll be circulating. And I'm told this is all being recorded. So you speak in the microphone if you got a question. Stick your hand up, and they'll bring you a mic. Our first panelist is Carolyn Clancy, who serves as director of the Agency for Healthcare Research and Quality, also known as AHRQ. AHRQ is the leading federal agency charged with improving the quality, safety, efficiency, and effectiveness of healthcare for Americans. Dr. Clancy is a graduate of Boston College and the University of Massachusetts Medical School. After clinical training in internal medicine, she was a Henry J. Kaiser Family Foundation Fellow at UPenn, an assistant professor in the Department of Internal Medicine at the Medical College of Virginia before moving to AHRQ in 1990. She served as AHRQ's acting director and director of its Center for Outcomes and Effectiveness Research before taking charge. She's currently also a clinical associate professor of medicine at George Washington University School of Medicine and a senior associate editor of a very important journal in this field, Health Services Research. And her major personal research interests include healthcare quality, patient safety, and reducing disparities in care associated with patients' race, ethnicity, gender, income, and education. As director of AHRQ, she launched the first annual report to Congress on healthcare disparities and healthcare quality. Our second panelist is Shelley Greenfield, a professor in the Department of Medicine, as well as executive director of the Center for Health Policy Research at UC Irvine School of Medicine. He graduated from Harvard College and the University of Cincinnati School of Medicine and completed internal medicine residency and a fellowship in infectious diseases at the Beth Israel Hospital in Boston. He previously served as director of the Primary Care Outcomes Research Institute at the New England Medical Center, Tufts. In the past, he's been with the University of California, Los Angeles School of Medicine and Public Health, working with the RAND Corporation. He served as co-director of a joint RAND-UCLA Center for Healthcare Policy. He has pioneered research in increasing patients' participation in care and using outcomes to determine the value of that participation. And today he's one of the nation's leading clinicians looking at outcomes research. He's had a lot of assignments running committees and national searches into answers, looking at answers to the questions that we're going to be discussing. In 1984, he was the medical director of the Medical Outcomes Study. He's been principal investigator of the Type 2 Diabetes Patient Outcome Research Team, chairman of the Diabetes Quality Improvement Program. I'm going to skip through a few of these so we can get to hear from him, but most recently, working with Harold Sachs, he was the co-chair of the Institute of Medicine Committee that looked at the national priorities for health effectiveness research. And MD Anderson and every health institution in the country sent in a list of priorities, and they picked the 100 most important things to examine. It was a very important study, and we all now use that as a basis for our thinking. So, last but not least, he's an old high school friend, and we grew up in Cincinnati together. So please join me in welcoming our two panelists, and they'll take over.
Good morning, everyone. And John, thank you for a lovely introduction. The one anxiety I wanted to put to rest is actually the summit is tomorrow. I didn't actually want to imagine that we were competing with what could be real theater. It will be televised all day from 10 to 4 Eastern. So for those of you who have the capacity to watch this at work, anytime things get dull, you'll have something to look at. I'm really delighted to be here. We're funding and supporting some very important work in this area and hope that we keep doing so. But I wanted to talk about, I'm also thrilled to be talking about this kind of research because at the end of the day, it is not research, it is not only research to generate more publications and better methods and better science. It will do that. But it is really about transforming healthcare. So I'm using the keyboard. Oh, wait a minute. I'm smart. I got it now. So almost 15 years ago, Andy Grove, the Intel guy, wow, finds out that he has prostate cancer and is really quite surprised that he can't go ask two questions that all of us want the answers to. What should I do? And where should I go for that care? If you think about it, us personally, our family members, my dad, everyone wants this kind of information. And I think the new focus and the new resources on what we're actually now calling patient-centered health research are going to be a huge part of building the infrastructure to be able to give people just that information. So what I want to talk about very briefly is the right care for the right patient at the right time. Making the right thing the easy thing to do. How many of you actually see patients? Right. Keep your hands up if it's like easy to do the right thing. Okay, right. It often requires amazing acts of heroism for clinicians in daily practice, and it doesn't have to be that way. That wasn't the 11th commandment from Moses. And then close with some thoughts about the kind of healthcare system that I think together we can build. So for those of you who haven't heard of AHRQ, this is just AHRQ at a glance, the effective healthcare program with the little star there. Not specifically for Texas, but not bad. We've had on some level, AHRQ is 20 years old this year, and you can make an argument that a focus on relating the process of care to outcomes that people experience and care about has been part of our DNA for that entire 20 years. We got explicit authority, though, in 2003 as part of the Medicare Modernization Act, or drug bill, which directed us to add two new components. One was that researchers don't set the priorities. Technically, for our work, the Secretary of Health and Human Services does, after being informed by very broad input from the public sector, private sector, and so forth. And this is all very transparent. Support for the research, of course. And then the third piece of this new language says that the research program has to lead to and result in information that's accessible by multiple audiences. Now, I would submit that there's not a researcher breathing who isn't passionate about making a difference in people's lives. That passion is not equivalent to the skill set to be able to communicate fairly complex information to people with limited health literacy and so forth. So that's why I'm thrilled that we are funding the John Eisenberg Center, which is right here in Houston. So keep up the good work. When people start to get too geeked out or scared by this stuff, the first thing I do is send them consumer guides, and they look at it and say, oh, yeah, I'd like this. You got any more of those? So, now, good news on our budget this year. Our budget for the current year, 2010, is $397 million, and the President's proposed budget would bring us up to $611. Actually, it's a tiny bit less than $611. All of this increase is in patient-centered health research, which is a huge increase over our core appropriated dollars. These numbers do not include the additional resources from the Recovery Act. There's also continued support for our work in health information technology, and quite a bit for continued work in patient safety, which has also been a big feature of the work that we do. And frankly, I think there's a very important kind of link that still needs to be explored between harms and adverse effects unintentional from treatment and trying to think about a variety of interventions and options for diagnosis or treatment that have sort of different profiles of benefits and harms depending on people's individual risk factors and so forth. Now, this past year, people have found the idea of comparative effectiveness, even with a friendlier sounding name, a little scary, right? Am I going to be denied access to care, to something that would help me a lot, based on studies that don't include people who look like me, and all kinds of very scary ideas about how the information will be used? And I think one of the scary ideas is that our team funded by AHRQ will come up with a report that says, option A, thumbs up, right? The market rocks. And option B, don't use it at all. Now, those of you who see patients will know that it is actually extraordinarily rare that those are the two choices. In fact, none of our reports have said one option is clearly superior. It's all about stratifying which patients are most likely to benefit from one type of approach versus those that are likely to do better with a different type of approach. So it's not yes or no. So I was trying to think of examples from other spheres of life, and so it's a little bit like asking which is better, a wooden bat or an aluminum bat. And the answer is it depends on the purpose you're using the bat for, who's using it, under what circumstances, and so forth. That's how we think about, excuse me, this kind of research. So this has been an extraordinarily busy year for us. I often say I have not had a lonely moment since about Thanksgiving of 2008. Shortly after the election, folks on the Hill got to work writing bills, and our phones rang off the hook. They probably rang on Christmas Day. I wasn't there to check personally, but throughout that whole period, people were working furiously, and as a result, there was an unprecedented investment in this kind of work as part of the Recovery Act. Now, this included $400 million for NIH, $300 million for AHRQ, on top of $50 million that we got from as part of our usual budget, and then $400 million to the Office of the Secretary. Now, the Office of the Secretary has no aspirations to create her own research institute, and in fact, all of that funding is being allocated through various components of HHS, which I think is a good thing, and probably close to half of it is being allocated by AHRQ. But we have tried to continue this same spirit of transparency and looking for very broad input about priorities, about specific questions. And for AHRQ work, we actually encourage and actively solicit people to review draft reports, which are posted online. So, the definition, what is comparative effectiveness? I hope you'll take a deep breath and be happy that I'm not going to read this out loud to you. A couple of points I would like to emphasize beyond the fact that this was obviously written by a committee, because all of those definitions have to be too long. One is the focus on real-world settings. The purpose of this research is to improve health outcomes through the conduct of research. And a very key phrase in terms of priority setting, responding to their expressed needs. Not what researchers think clinicians and patients might like to know, but actually that physicians, patients, other clinicians are very much part of an ongoing dialogue about what's important. So when we look for feedback on priorities, it's not just at a very high level, it's also at the level of the specific questions. Speaking as a clinician, I can tell you it's very common if you take care of patients to be inspired by something that happens in the clinic as a question that you want to address through research. Many times what you find is that you actually do some pretty cool research, but it's several degrees of separation away from that original question. Our aspiration is that this work that we're funding is both relevant and rigorous. So you can stay tuned to see if we're getting there. You know, ultimately, we've had an enormous opportunity since we launched our effective healthcare program in 2005 to, frankly, have a leading role in federal funding. And I'll tell you what, we don't want to invest a single dollar that someone else is investing. So there's been a lot of discussion about should the home for comparative effectiveness be public or a private sector entity. It is an enterprise now, and we've had a lot of really terrific collaborations with the private sector, and I can't imagine that going away. But ultimately, a lot of the output here is about hardwiring a healthcare delivery system that makes the right thing the easy thing to do, that actually gives you good information when you need it just in time. Technologically, this is not hard. Think about Amazon, right? I get to hear when Amazon always lets me know when Bruce Springsteen has a new product, and thankfully actually tells me nothing when Britney Spears has news to share. So we know how to tailor information and deliver the right information to the right point in time to the right person. What we need to do is organize the science to support that. So again, these are the conditions that actually guide our work. We're not, there's a lot of ways that you could think about priorities. It could be by types of service, drugs, devices, surgery, and so forth, or you could take a broader frame. These are updated periodically, and we also have a process for going outside these specific areas. So we're not necessarily comparing drugs to drugs. We might be, in the case of gastroesophageal reflux disease or heartburn, looking at drugs versus surgery, sometimes versus doing nothing, and so forth. These are just pictures of the work from the Eisenberg Center, which I'm extraordinarily proud of. But the point is that there are different products really tailored for different audiences, whether you're talking policymakers on the left, a brief clinician guide, or the guide for consumers. I have to say Consumer Guide for Prostate Cancer is one of my favorites. Unfortunately, I've had the opportunity in the past couple of years to share this with some close friends, but it actually gives people a very clear sense of what are the options. And it turns out there's 4 options if you have localized prostate cancer. You can have surgery, radiation, hormones, or watchful waiting. And we don't know which is best. And this portrays that information in different ways for people to get their heads around. And what several of my friends have loved is it also has a list of questions that people can bring with them when they go to the cancer center or to see a specialist and so forth. And I think that's exactly what we need. I don't think the end game here, by the way, is pretty brochures, although they're nice to be able to hand out. I think it's got to be iPhone apps or WP7 or whatever the new Microsoft. I mean, it's got to be almost impossible to avoid, and you shouldn't actually need to come into clinical settings to get it. That would be my view. Very, very proud of the Center for Education and Research on Therapeutics in Houston. This is one of 15 national centers focusing on safe and effective use of therapeutic products, and their focus is one that has been a long-standing challenge, namely consumer education and patient adherence. The CERTS program, not to be confused with the Breath or Candy Mint, also has a website that I would commend for your attention called chainonline.org, which is the Clinician Consumer Health Advisory Information Network. And the focus here is on anticipating emerging therapies so that people have some sense of what's coming online. This is just what guides all of our investments, and it's very, very similar to what guides the investments for all of HHS. Very strong focus on input from multiple stakeholders. I'll be the first to say that when I say this at home, my husband says to me, "What is a stakeholder?" But what I mean is people who receive care, provide it, pay for it, do research, and contribute to what I think will be a very vital enterprise. The horizon scanning speaks specifically to an effort to try to develop a scientific methodology for beginning to forecast what are going to be the most likely treatments emerging in the next 3 to 5 years. We're going to need economists, social scientists, all kinds of folks working on this because no developed country has figured out how to do this well yet. We'll continue our work on evidence synthesis, generating new evidence, and also continuing work on training and career development. These are just some examples of the work being funded by the Office of the Secretary's portion of that Recovery Act money. The point is that some of the best advice we got in listening sessions and from people giving us input online about how to invest that $400 million was that it should complement what AHRQ and NIH already do. And so we took that opportunity very seriously to try to think about how we could build an infrastructure and begin to make a down payment on an infrastructure that would be available to researchers across the country for years to come and essentially accelerate the whole enterprise. So we're looking at a variety and supporting a variety of efforts to create the kind of data sources that are going to be necessary for this, including distributed data networks. This is an approach where multiple healthcare organizations participate in research through a collaborative approach together, but instead of making one large database, which always makes people very, very nervous about their personal health information being used for a purpose that they weren't informed about, their data stay where they were generated, but because of common data definitions and a common infrastructure, it's almost like a Google approach, to put it very simplistically. A lot of focus on patient registries. Just one that I really want to brag about here because I'm very, very excited to see what came in, and to be fully transparent, Dr. Greenfield is associated with one of these applications. I have no idea. They're just in process now, going to be reviewed, is something called the Clinical and Health Outcomes Initiative in Comparative Effectiveness or Choice. This is the first coordinated national effort to have a series of pragmatic clinical effectiveness studies with a strong focus on populations traditionally underrepresented in much of clinical research. By pragmatic, I mean what we're looking to create is sustainable infrastructure so that the next study is very easy to do, because this study did not depend on a huge army of people coming in, which is usually how we do clinical trials, and then when the study's over, they all go away. What we're trying to figure out and work towards is the idea that information generated as part of delivering care can actually be part of helping us get smarter. So one other announcement is that we think that public dialogue is absolutely essential. I think many of you probably come sympathetic to this topic, to this symposium, and I'm looking forward to hearing questions and so forth. But many people are quite nervous and anxious about this. They're worried that they're not going to get the care that they need, or someone that they care about will have the same experience. So this year, as part of the Recovery Act funding, we will be supporting a citizens forum on effective health care. The contract was just released yesterday. So if any of you are interested in that, I would commend that for your attention. One last point I would like to make is this strong focus on infrastructure, which sounds like building railroads and so forth. I think the major point is that investments that support comparative effectiveness and trying to get to a what some have called a learning healthcare system will also be critically important to us supporting efforts to assess and improve quality of care, and to be much, much smarter about post-marketing surveillance so that we can actually understand much earlier in the process about risks and benefits. Because the second piece of theater going on this week in Washington is not the summit, but it's new concerns about the diabetes drug Avandia. So with that, let me thank you for your attention and thank you for your patience. I think I went a couple of minutes over. Looking forward to the discussion.
I also want to thank John for the introduction. He was a hero of mine in high school. I was several years behind him. He was a hero of mine when we were Harvard undergraduates, and he remains a hero of mine. So it's a very great pleasure to see him and to see many of you. Now I'm going to get a little bit more granular and a little more focused than the broad picture that Carolyn presented, and talk about comparative effectiveness research. Since the report was issued last summer, several, and I'll name three, circumstances have enlarged my own personal picture of perspective about comparative effectiveness research, and I'll name them, and they will come up again in the future. One is that just by chance, somehow, coincidence, I'm current chair of an Institute of Medicine committee on clinical practice guidelines, setting standards for clinical practice guidelines. And even I've been in this field for a long time. I'm shocked about, if you will, the state of the art of guidelines and how complicated the things actually are. We had a wake-up call, as you know, with respect to mammography, and I'll mention a little bit of the implications that I've learned so far about the way things need to go forward. Secondly, we had a paper in the Annals of Internal Medicine ourselves on effectiveness research that incorporates a lot of the elements in the major definitions. It was on diabetes, it wasn't on cancer. It just came out a little while ago in Annals. What was interesting about it is not the topic itself so much, but the run-up to the topic, which is its review and the reaction afterwards, which I'll describe in a little bit for you. And third is that we are part of several applications, some of which are extremely interesting and imaginative. One of them, and it is a little awkward to talk about it, is on prostate cancer. We're just a small part of it. But it has four features which are right down the line, as I will mention in a minute. One is it comes from community-based samples. Second, there's going to be pre-treatment information. Third, it's extremely interdisciplinary. In fact, it seeks to compare surgery to radiation. And one of the key investigators is from MD Anderson. I don't know if she's here today. I haven't actually met her. And fourth, there will be an attempt, and this is partly what our function is, to separate the quality of the operator from the procedure itself. And whether this particular proposal lives or dies, its descendants will probably, hopefully, incorporate some of these features. Now, I'm going to basically raise two questions in this short period of time. Will CER go forward? The reason I raise the question like that is to note that, at least in my view and the view of many others, it is independent, and it can be independent of health reform, of what is happening in Washington. And so I'm going to try to answer that question, at least my view of it. And secondly, one that was hinted at, does CER represent a transformation of research, or is it simply an add-on from outcomes research and other things that have been around for a while? So I'm going to address those two questions very briefly. The answer to the first question, I think, is yes. And it's not because of Carolyn only. Carolyn and her team play a big part, but there's huge interest in all sectors. And I know there's huge interest at MD Anderson. There is interest in the pharmas, for example, which influenced me a lot because you wouldn't think they would necessarily go along. And I had meetings in the last month with two people at high levels in the pharma industry, and both of them are terribly interested in this whole thing going forward, for their own reasons, of course, but they still want it to go forward. So I'm going to drop this question, and not if there's questions about it, we can answer them later. But I'm going to go on to the second question about the future of CER research and what it represents. This is the definition from the IOM report. You can't read it. I don't want you to read it. It's in the report. I'm sure many of you have seen it. But I just want to single out two features, both have which been alluded to before, and I want to focus on them. One is head-to-head comparisons, which head-to-head comparisons are comparing something to what's already available, which, by the way, happens in cancer probably more than many other spheres already. That's one feature. But the other feature, in a way more important, is the focus on individuals or subgroups. As we all know, and as I'm sure Don Barry will always remind us, you can't really predict very much about an individual batter coming up in the ninth inning with 3 people on base and so forth, but you can say something about a small population or a larger population or a subgroup of some kind. And that's the focus that I want to just delve into a little bit this morning. Now, first, on the first topic very briefly, I want to point out the second issue is with respect to comparators, the differences are going to be smaller, almost by definition. And that makes a big difference to funders and to planners, because when the differences are small, and I'm going to return to this issue, it changes the nature of the willingness of people to go into research. So I just want to point that out. For the patients and for the doctors, hopefully this is exactly what's needed. But for researchers, it does alter their way of thinking about certainly initiating and maybe even carrying on research. Now, this slide is not to go through all of the topics, but I just want to point out that this could be, I don't know if you can see this very well. Can you see it? This is what I think could be the beginning of a paradigm, which is the broadening of research. Up here are trials, and you can see that I'm listing, I'm not going to go into them in any depth, but there's a lot of feeling everywhere for all kinds of reasons, multiple reasons, that classic randomized trials are only going to be part of the answer, and maybe even an increasingly smaller part, even though we adore them and we live by them. But there are other kinds of things that are mentioned that are going to climb to higher evidence. Pragmatic or practical trials, and Carolyn herself was part of a paper in JAMA early on, 2003, with Sean Tunis on this notion of more practical, pragmatic trials in communities. There's adaptive trials, and Don Barry has pioneered this, and I think there's going to be a lot more activity in this area. We ourselves are working on something related to adaptive trials. I'll mention this, come back to this later, which is stratifying or defining subgroups before the trial actually begins. This could actually aid in adapting things later also. But it's the idea of finding the populations that are often left out and most likely to work. I'm going to return to that theme. Others, N of 1 trials, cluster trials, there's a whole series of new potential types of trials that are basically broadening. Now, this is just my classification. Other people classify things slightly differently. And of course, this is where a lot of the talk is. And John Mendelsohn and I were talking last night. There's also quite a lot of magical thinking, I think, about this, or illusionary thinking. about how much registries and databases will be able to do the job that we would like them to do in new settings. But there's, of course, as Carolyn pointed out, enormous interest in creating a patient, be able to get patients from spheres that we have not gotten them before and look at the data for them. So registries, infrastructure, databases, and of course there's still the old-fashioned way of assembling an observational study. And then of course there's data synthesis, which I'm not going to talk about today, systematic reviews and modeling. Now to go into comparative effectiveness research in the new, larger mode, there's going to have to be more researchers. As I mentioned, and Carolyn mentioned, there'll have to be more of database development. Interdisciplinary teams, people that have not really worked together before, they have to start working together. And then something that very few people are talking about, so I'm going to be talking about it today a little bit. It comes from my own experience in guidelines and in quality measures, which is acceptance and understanding of new forms of data and evidence. And I bring this topic up because now we have research, then we often have systematic reviews, and then we have guidelines, and then we have either quality measures or rules for electronic medical records, which is the new thing. And these four spheres it turns out, this is the new revelation that I've become to appreciate, often have relatively little to do with each other when they should be completely interdigitated. It's a little bit like different cancers in the same cancer institute, people not talking to each other. So there are going to have to be, I feel, new ways of accepting and approving evidence and putting it out to the public, including clinical receptivity to new forms of evidence. As you know right now, most reviews say, well, observational studies, they're great and everything, and then when it comes down to it, only the trials go into the systematic review. That's what usually happens. And for harms cannot really be dealt with at all, or hardly at all, in trials. They have to be dealt with in other kinds of studies. We need standards for observational studies to go into systematic reviews. There is a parallel systematic review committee right now at the IOM. Standards for guidelines, which is being worked on. And I want to point out something that came about very strongly, forcefully in the mammogram set of issues, which is separating evidence from valuation or subjectivity. Not that we necessarily can do anything about it, but there's a lot of conflating opinion or evidence or valuation or subjectivity on one hand from evidence on the other. So I just want to say that down the road, downstream, if you will, we have to also accept potential new forms of evidence. Should remind everybody in the room, we all know this, there still has not been a trial of smoking versus non-smoking in the development of lung cancer, and yet we're perfectly happy to accept the evidence that we have. Now, this is just my diagram. Everybody has a different one about how things flow from the lab. Again, I mentioned multiple new kinds of trials, observational studies, new evidence, moving into systematic reviews and data synthesis, guidelines and performance measures, and now electronic medical record rules. And I just want to just reinforce what I just said before, is these things are going to have to come together. It's kind of shocking how sometimes far apart the systematic review people are from the research people, and how far the systematic review people are away from the guideline people. And there's a huge gap between the guideline people and the quality people. And they all have different imperatives, but there's a lot of things have to come together so that they work together. Now, I want to make two observations, and then I'm going to talk about subgroups a little bit in my talk here. One observation, and this is again my own opinion, I want to make sure that's clear, is that CER can be, and I think should be, independent of cost effectiveness of coverage and coverage decisions. Now, I know this is a hot topic, very controversial, but I'm just giving you my opinion. I personally think that CER can go forward with complete and total integrity, short of and unrelated to coverage and economic decisions and cost effectiveness, which can be done at a later point in parallel. I also think it clouds things up politically, but the main reason is that they each need to have their own life and integrity. Second thing is, I'm not going to review this in detail. Carolyn kind of mentioned it. There's going to be pushback of what seems quite benign, comparative effectiveness research is benign, but there's pushback. And Carolyn mentioned the possible pushback from patients. Here's evidence of pushback from a well-known medical writer, Jerry Groupman, who writes a lot for the New Yorker. He had a piece which I would all recommend to you, a lot of fun to read it, going after CER head-on in the recent New York Review of Books. And he went after the whole field. And so I'll just comment in defense, short defense, that what Jerry sometimes does, and he might represent many physicians and many patients in this country, is conflate different parts of the process. For example, he talks about best practices in tight glycemic control and intensive care. And there is an example of it's not so much the evidence, it's the reversal. New data came along, and when new data come along, that's just the way it is. You can have a guideline, but when there's new data, you have to change things. And it's always going to be like that. And it's probably a relatively small number of things in which new data come along and completely reverse what we knew before. Everybody thinks of hormone research and so forth, so there are outstanding examples, but they're probably relatively rare. And we have to keep that in mind. Statins and dialysis, again, a reversal later from new data, erythropoietin and so forth. So I just want to point out that there's the research itself has to be separated. Criticism of the research itself has to be separated from what's done with it afterwards. Now I want to talk a little bit about subgroups. There was a very good article in JAMA a little while ago showing that within trials, these are the patients who are most responsive down here. These are the bulk of the patients up here. It turns out the average is somewhere in the middle. The average in a trial very often represents a relatively small number of patients, and often not the most important ones. Why? Because to do blockbuster, to include it, we often end up having larger and larger trials with more and more people who can only benefit a little or not at all. And that drags the answer down and dilutes the trial and makes trials either negative or having small effects, which is not fair to the people who work over here or to the patients who can benefit. So I just want to point that out because that's an ever-increasing field and has to do with the creation of subgroups. So this is a hypothetical example. You don't have to read the small print. You can just see this happens to be for cardiac disease, clopidogrel, using data that's already out there. There are some subgroups, if they were preformed, who could benefit hugely. This is an absolute risk reduction, not relative. Benefit hugely. The ones that are often in prior small trials. Then there's this group that can hardly benefit, the one I mentioned, very low risk. But there's a lot of money in here in between, which is patients who benefit to some degree, and in a cost-effectiveness analysis would do pretty well. Also to some degree, maybe slightly less. Maybe there's 4 or 5 or 6 groups or 7 or whatever it is. But dividing the patients into subpopulations, and of course that's a huge issue in cancer. Not that there aren't thousands of subpopulations, but if we're able to carve out some reasonable number and patients can find themselves in these reasonable numbers, we could come up with different answers, quite different answers for each of these subgroups. And so our notion is to try to form them as much as possible based, as Don points out, on whatever data is available from prior studies and so forth. And this is just an example from diabetes in which it's just the complete reverse. In diabetes, it's the complete reverse. Younger people, turns out, without any disease, actually do better. And so if these subgroups were preformed, we would be able to sort out different levels instead of a yes or no answer. And Carolyn kind of alluded to, instead of a yes or no answer, we have multiple answers for different subgroups in which a patient might find him or herself. Now I just want to mention this study of ours that just came out in which we compared, this is for diabetes, so it's not on target for cancer, but in which we compared 2 levels of treatment, intense and less intense, in 2 key subgroups, high comorbidity and low comorbidity. And over a 5-year period, we found out that the differences were huge, such that they will be clearly incorporated. This study and others like it will make it sure that they'll be incorporated into guidelines and outcomes. And I only mention it because in the review, it's the usual thing. It's an observational study. Say, well, you know, observational study is not causal, and so forth and so on. But the reaction to this in a community that we expected a lot of negative reaction has been very muted. And the reason it is that putting an observational study that is carefully done along adding them up into the 4 trials plus 2 or 3 other studies has fashioned a picture which people now accept, which could not really have come from any one of the trials or even any 2 themselves. So that's an example of how these, if you will, the synthesis of multiple forms of information can come up with answers that we didn't have before that are relevant to key subgroups and maybe even individuals in a population. This we also, by the way, did in cancer. This is prostate cancer, in which comorbidity had its own life. Everybody knows that about prostate cancer. And this is a paper in Cancer from a couple years ago in which we showed that patients with high comorbidity, as you might expect, have a shorter lifespan, and you can't count that against the prostate cancer treatment. So it affects, and this is increasingly going to affect cancer treatment of all kinds. Now I just want to make one more comment, and then I'll end, which is the attempts in the cancer world. I'll talk more about this later. NCCN, ASCO, and CA-BIG to start this process going. I only point out that this is mostly about guidelines, this is mostly about quality, and this is now mostly about software. So the big question is, you're laughing, the big question is, can these be, if you will, can they morph, can they be transformed into the kind of databases that will have outcomes attached to them, all the right covariates, all the good baseline data, all the co-management treatments and so forth, such that we'll be able to do. Now, it's an open question, and some people are going to be more skeptical about whether they can or not, and I'd be glad to give my opinion in the question and answer period. Some people think it's going to be relatively easy, but we'll see about that. And I just want to mention the adaptive trial I mentioned before. I think this is going to be a very important set of advances, and this comes right here from home. So, will comparative effectiveness research go forward independent of what happens in Washington? My answer would be almost certainly yes. Secondly, does it represent a change? And in my view, it does. And in my view, it could represent a very positive change for the research communities involved and for patients in general. Thank you very much.
Well, it's time. Thank you very much for 2 excellent presentations. It's time for questions, and while people are collecting their thoughts, I might just take the prerogative of asking the first. Everybody knows that there's a big push for an electronic medical record. Could either or both of you comment on what needs to be done to make this a very effective tool in measuring health care effectiveness?
Sure, I'll start. First, let me just make the observation that most electronic health records for those physicians, hospitals, and others who have adopted them were designed to support a system that rewards volume rather than value. Okay, so docs get paid to see more patients. So capturing the complete content of care, upcoding, is way more valuable than, say, having the capacity to have a registry in place so you can look back periodically to see how are we doing with our diabetic patients, or in screening patients and follow-up, or, fill in the blank, because you don't get paid for that at all. And I'm not being cynical. I'm just saying that is not a routine part of practice, and I would submit needs to be in the future. The trajectory that's been laid out by the Office of the National Coordinator for Health IT, the National Coordinator is a physician from Mass General named David Blumenthal, who is not what we would call a gearhead. he is all about improving healthcare quality. So across the department, with input from many, many people, we're trying to figure out how do you build those kinds of records so that actually the data that you want for research are retrievable. It's a big part of our work supporting these distributed data networks and so forth. It's not happening tomorrow. I mean, I want to be appropriately modest in terms of how long this is, because that's not how some of these products were designed. But the link to the financial incentives for under Medicare and Medicaid for adoption of health IT, I think will be a very important push.
I agree with Carolyn. I heard David Blumenthal, I was with David Blumenthal at a meeting a little while ago, and he said something like, yeah, when I practice, there'll be a red light, a yellow light, and a green light telling me what to do next, what step to take next. And then he laughed and said, but we're not quite ready for that yet.
We'll never be ready for that.
Yeah.
There was a question back here? Yes.
Given the current fee-for-service system that we have, comparative effective research may result in financial winners and losers. Do you expect, and how might you deal with organized disruptive resistance from clinicians similar to, say, the spine surgeons years ago?
My favorite question, but a very, very important one, so thank you for that. When I talk to friends, colleagues, and so forth who spend most or all of their time providing patient care, they're actually pretty thrilled to get information in real time, those who have the opportunity, about what works for which patients. If you watch ads on TV for pharmaceutical products and the like, there is this implication when it says ask your doctor at the end that all doctors have instantaneous access to side-by-side information customized for you. Now, the irony there is that is precisely what physicians aspire to do. So part of my answer would be that we need to be just as transparent in terms of how the research is used as we are about or at least as we are aspiring to be about the conduct of the research. That's why I think this Citizens Forum is going to be very, very important. Our work has been guided by a stakeholder panel for the Effective Healthcare Program, which has been enormously invaluable. I think ultimately, if clinicians can have, pretty rapid access to information that helps them do a better job, that's going to be fantastic. And as I tried to say earlier, most of the products and work that we've supported is not a good match for coverage. It might ultimately one day, and I do mean one day, not anytime soon, be a good fit for what some economists refer to as value-based insurance design. In other words, if Shelley is someone who would benefit from bypass surgery as opposed to medical treatment or stents and so forth, then Shelley's copay would be zero or a lot less than, say, me, if I would do just as well on medical therapy. Now, you have to match that idea, which I love, against the current systems and current, it's not uncommon to read a newspaper story even today that says health plans don't have an accurate list of their doctors. So I think we're a long way from that kind of precision, even though some large employers are starting to put their toes in the water in this regard with respect to co-payments for medications, because they find that people above a certain threshold sometimes stop taking them, and that means they get to work less often. So suddenly they see what's in it for them. So I don't think it's going to be an easy road, but I think, young docs growing up today in an information age in all aspects of their life except for the practice of medicine will ultimately demand and sort of expect this.
There are a lot of assumptions that are made by both of you which are implicit, and rather than, I just want to consider one of them. The guidelines that you refer to and the judgment as to what is a more appropriate therapy frequently today comes from meta-analysis studies. To my limited knowledge, there's only one case where a meta-analysis meta-analysis, actually set of studies, can be compared to a conclusive clinical trial. And that's the estrogen therapy for postmenopause. In that single case where that comparison exists, the meta-analysis results were diametrically opposite to those of the more definitive and reliable large-scale clinical study. To which my first question was, why are we still doing meta-analysis?
Well, I'll start off responding to that. I appreciate the question. I'll even trade you another example from diabetes, which I work in heavily, which is there were 3 trials recently showing one, all agreeing with each other, showing no effect. 2 subsequent meta-analyses published in good journals, Lancet and Annals, showing a positive effect. And we came along and helped it out a little bit, but there's another example in which, also in diabetes, that Hal Sachs got published in Annals last year, in which 2 models disagreed with each other. So I think the Systematic Review Committee, which is now going on at Institute of Medicine, and by the way, which was part of the MIPA legislation, which antedated Obama, is trying to apply standards, if you will, to meta-analyses such that even though they're still going to suffer from the kind of things you're talking about, will raise themselves to the level in which we can count on them as being more reliable. And I also want to point out and disagree with you on this very last point, which is many trials themselves are either suspect or disappointing in many different ways as well. They are not necessarily the gold standard. So there's problems in meta-analysis and there's problems in trials, and all we can do is move closer and closer to getting both better. And there still may be, as kind of the implication of your comments, some uncertainty afterwards, as there was in the mammogram set of issues as well. So we have to do the best we can to provide the best evidence and the best analyses from meta-analyses. And I should also add that what will come out of this committee, I think, is there are many instances in which a meta-analysis should not actually be initiated, shouldn't be started in the first place, because it's sort of like seeing a patient. You have to make a clinical judgment as to whether the substrate of the studies warrants a meta-analysis. So even at that level, there's a lot of work to be done, and I know that there's some work already going on.
So I just wanted to build on that for 1 second and put it in a broader context. The research enterprise writ large, right, tremendously values discovery over work that focuses on application of science. And I would put meta-analysis in that sort of second bucket, synthesis and so forth. And a huge proportion of comparative effectiveness is going to be about that. What works for which patients, under which circumstances, and so forth. Most of the work that we support in evidence synthesis, a meta-analysis isn't even feasible. And in fact, often the most important product of that work, an attempt to do a systematic review, is feedback upstream to the clinical research enterprise that what pieces are missing and how future studies could be improved so that we could get some of the answers we need. The other thing I would say, and I'm not sure we've got good answers for this, and I think is very exciting methodologically, is one of the game changers here, and one of the reasons we've focused a lot on data infrastructure, is going to be the incredible urgency of building better methods for longitudinal assessment, right? I mean, if you think about where we need better science, it's all about people with chronic illnesses and multiple comorbidities, as Shelley said, and yet we don't have good methods for that at all right now. So we may look back at the current practice of meta-analysis. I'm thrilled by this work going on at the Institute of Medicine, and even more thrilled that Shelley is leading it. But there's a lot of methodological work that we need to do. So I hope I'm getting some of you excited about that, because there's going to be a lot of opportunities.
I enjoyed the evening, appreciate this, or the morning, appreciate both the information and the presentation. I serve on the board of the Harris County Hospital District, and it's an integrated healthcare system that primarily serves the medically underserved families. And apart from the hospital system itself, we have a very large primary care network that includes over 300,000 unique lives and almost 1 million ambulatory care visits a year. In this whole discussion about the comparative effectiveness, I have primarily heard, and I think very appropriately so, discussions on interventions. But we are now seeing more emergence of questions about processes in terms of how do you deliver care, and our population is probably overrepresented with patients who are typically underrepresented groups. So actually in the last board meeting, we had a discussion about, is there a way to use the network of clinics we have to maybe do, effectively it's a natural laboratory, to maybe do randomized trials on the process of primary care delivery. And so my question to you is this something that falls within the mandate of what you all are looking at in comparative effectiveness studies?
So let me say that another game changer of this past year, and interestingly, very independently, the Institute of Medicine committee that Shelley co-chaired on comparative effectiveness research and the Federal Coordinating Council both reached the same conclusion, which was that comparative effectiveness needed to include quote-unquote care delivery interventions. Now, the tough part of that is we all know what 20 milligrams of Lipitor is. We often don't know if people are taking it and so forth, but we don't have standard vocabulary frameworks and so forth for these processes of care. But ultimately, they often have a bigger impact. The effect size, if you get it right, is much bigger than a specific clinical intervention, and I think that has to be extraordinarily relevant to cancer in particular because people get lost. So, yes, I would say that it is very much part of that. And the other point I would just make is this issue of setting priorities for this work is very important, but it too is kind of a new sphere. There's a lot of reports, because we assembled them all for the first time. The Secretary set priorities for this work in 2005. There are many, many reports that set priorities once. Doing it in a longitudinal, ongoing way and figuring out the strategic benefits of going deeper in one area versus taking on new areas and so on and so forth, no one's done that yet. So it's a very exciting area, but I would be thinking exactly along the lines that you are.
Okay, let's go over here and work our way around.
Most drugs and devices are approved on the basis of studies that are conducted in very selected populations and not really on pragmatic trials. So I was wondering if you could comment on the role of industry and public-private partnerships in comparative effectiveness research.
Well, I would just say that almost everything we do is about public-private partnerships. I mean, first of all, the researchers we support, by definition, tend to work in the private sector. But we work collaboratively with industry a lot. I mean, huge depth of scientific capital there. I don't see that going away anytime soon. A lot of debate about governance of this enterprise, which is obviously at the core of the health reform bills in terms of should industry representatives have a seat at the table or be in the room and so forth. But frankly, all of the aspects of improving care that Shelley noted, where he said they should all be the same thing, but they're not, that kind of conflict or potential conflict comes up again and again. But I can't imagine doing this without public-private partnerships. Industry, on occasion, supports registry, sometimes at the direction of, or demand of our colleagues at FDA. Sometimes they do it because they've come up with a new product which is for a relatively small population, and they actually want to know how do people do over time and so forth. What the value proposition for them will be to do more of that latter kind of activity, I think, is an open question, but I don't see the door closed. You know, there is a script that says, and I heard this most recently from Pat Danzon at Penn, who is an economist from Wharton, that says that actually all of this work is the best thing that could happen for industry because it will help them target their R&D to areas where they're likely to make contributions of the greatest value. That's a 20,000-foot observation, and I like thinking about it. Getting it down to the ground level, I think, is going to be more the challenge.
Can I just add something to that? Because just 2 points to what Carolyn said. One is that I think certainly within pharmas, within the companies, there's some differences of opinion about this, and there are people who would agree with Carolyn that the value proposition for this work, there are many who feel that it will be in their favor and are willing to join. Let me also make a distinction, if I might, some of you might disagree about this, between pharma on one hand versus devices on the other. And pharmas, in some respects, look like choir boys compared to the device industry. So I think, and also I should also add that devices are harder to study because you have the procedure itself and the operator and the device, all three. Whereas with a drug, you just assume that the operator is giving the patient the drug and that's the end. So ironically, for all the difficulties we have in studying medications, they're much easier than these other areas. So I think the big turnabout has to be, the biggest turnabout, and maybe comparative effectiveness research will help it along, is devices and procedures. But I have the feeling that the pharmas are going to advance a little bit in this.
I have some concerns about practical considerations. You take a big fish in the pond like cesarean section. A lot of input, a lot of research goes into it. In certain areas in hospitals in Mexico City, Rio de Janeiro, in Beijing, where Nicholson Eastman spent most of his life and practically invented modern obstetrics, the cesarean section rate in those hospitals there, in that particular hospital, nearly 100%. Which is really weird when you consider what we're wrestling with in the United States. And I just wonder that as we come closer and closer to a rigid association with evidence-based medicine and comparative effectiveness research, what if healthcare costs come down far enough in America that tens of thousands of women would elect to have a primary, or would want a primary elective cesarean section? As a gynecologist, I don't do obstetrics anymore, I smartened up, but as a gynecologist, I see that in my patient population. So what would the government do? What would you advise the government do? Would they intervene in a statutory manner to forbid it if because the evidence is against it, or it's a dilemma for us because you can't establish a set of rules or a protocol and then have a substantial subset of the population just opting out of it. Do you have any suggestions about if you were running the government?
First, let me say I'm not a mother. I've not had that privilege. So I do recognize that this is a highly personal decision. I do actually hear from quite a few women, friends, and colleagues that they're surprised by younger women who work with or for them, all kind of sounding like they expect a section or thinking about that in a very different way, than my sister did, for example, who was completely depressed when she found out her own OB was going to be out of town and she might not be able to do that VBAC. I mean, she was horrified, probably misinformed, but also worried about it, and she was successful. I don't think the government's got a role here at all. I think the government's best role, and politically the most sustainable strategy, is that the profession emerges and the various specialty groups and so forth to actually lead the way, both in conducting the science, the use of that information and so forth. But I'm not sure this is the best example because there are obviously, as you pointed out, a number of countries where cesarean section rates are very, very high, and at the end of the day, I would probably say that's kind of the patient's choice. Now, in the past, we've kind of acknowledged this for a whole variety of decisions. I don't see today's baby boomers and their children and so forth just kind of saying, Okay, great, I'll do what you want. I think they're going to expect much more of a participatory role. So I think we'll see how that all shakes out. I'm very encouraged about how many leading professional organizations, particularly in the physician world, are developing registries, take this very, very seriously, and boy, once they get into it, they are so excited because they can actually begin to have information that they didn't have before.
Over here, and while Mike's walking over, let me just comment that what Carolyn said is so important. And if our federal government said to the population of the United States, we're not going to tell you what to do, we're going to give you transparent information and let you work it out with your doctor, and we'll sign it in blood, I think we could get a bill passed next week. I think that is the key issue that there is still confusion about, and especially the Democrats have not put that to bed. It would be wonderful if they could just say, that's it. We're not going to tell you what you got to do. You work it out. We're going to give you information. That's my opinion.
Let me add to that as well, because these are more nuanced discussions than we usually hear. And I don't know if the Syrian sections are the best example either, as Carolyn said. But if there was counter evidence to show that the satisfaction of the population was very high, patient satisfaction, and maybe some future life thing is also part of the evidence. Now, in that case, it may be stretching it too much. But as John pointed out too, and because I see patients myself, and I'm trying to get people not to take antibiotics when they come in with a cold. It's a daily struggle, and we continue it every single day. But by and large, things are starting. The tide is turning. And if you had a situation, and MD Anderson might be in this situation, which you said, yeah, the average, there could be a rule that applies, but if in some places or some people there's 10 or 15% more utilization, fine. Now if it gets up to 100%, maybe, but if that level of, that kind of flexibility must be a part of what we do.
Well, I agree with Dr. Mendelson's comment about getting consensus, but I wanted to segue on Dr. Greenfield's comment when you spoke about procedures, devices, and so on. If you're developing national standards or guidelines, as a layman, I can sort of get my arms around being able to evaluate pharmaceuticals on a data basis as whether they're effective or not. But when it comes to surgeries, if you have national standards and guidelines, for example, do you clip a brainstem aneurysm or do you wait and try to coil it on the margins of a malignant brain tumor? What risk do you assume on essential functions versus getting the margins? And then how do you nuance that on a national basis against the skill? Dr. Greenfield used the term operator. I would say the surgeon, and the effectiveness of the post-operative procedures at that institution for enhanced outcome, whether it's cardiovascular or whether it's cancer therapies. It seems to me there's a huge bunch of moving parts out there that for the lay public to be informed and have the alternatives that you'd have in any kind of national standards or guidelines, which, as Dr. Mendelson said, I would hope would at most be suggestive as opposed to rule of law. But could you comment on how you go about nuancing some of those features?
Well, if I were a young surgeon in today's environment, I would think that I died and went to heaven, because this could be the flowering of the kind of research. If you imagine what cancer research was like 15 years ago and what it is right now, you could see that device research could make progress and deal with some of the very thorny issues that you raised. As of the moment, we can hardly imagine them even being tackled because of the potential complexity. But you look at other fields and people would have said that also. So I see a big future in at least attempting to address the concerns that you have, because right now we pretty much know we pretty much know almost nothing. Robotic prostate surgery, another fine example of that, and maybe that'll be addressed, but a little sooner than brain aneurysm. But I see this whole field as starting to work on topics that you raise.
Okay, time for just a few more questions. One up here, Ron.
I'll speak loud. I'm not going to come across as anti-diabetes, anti-blood pressure, anti-anything else, but I am going to make an impassionate plea for cancer.
Yeah.
It is your slide you put about the NCCN and ASCO type databases. I'll leave CA Big alone right now. As you know, we're proud founding members of NCCN, and Bill McGivney is a very good friend. But the fact of the matter is, of the NCCN databases, well over 80% are breast cancer, 5% or so are prostate and colon and lymphoma, and then the rest is just a very small number of the other diseases. And the orientation, as you said, has been very much on process metrics, concordance with guidelines, and as intuitive as it is, that should lead to better outcomes in the long term. That is yet to be proven. The ASCO COPI process is also predominantly process metrics, and we have a huge need. If it weren't for very aspiring departmental databases that are disease specific, we probably wouldn't even have the outcomes measures we have. So I did want to thank you for your recognition that we need a lot of development as far as the outcomes side of things in cancer, and getting databases do that. My question is, so kind of like I led in, as far as the AHRQ granting process go, you've got diabetes, arthritis, heart disease, cancer, all of it, high blood pressure, all other sorts of conditions. How are you possibly going to assure that a rational allocation of the funds occurs, or there is at least everyone's represented, or is it just the best projects, et cetera, and maybe some of them will be left out altogether? How's that going to occur across all these different diseases and interests?
Well, so that's an incredibly important question. Thanks. The short answer is it's going to be a work in progress, and I think that that's why we think that the participatory nature of everyone who's connected to healthcare, which is kind of everyone, is going to be vitally important. I will say specifically for cancer, one of the investments made with the money allocated to the Office of the Secretary has been to do some pilot work with the existing cancer registries to come up with and implement a sustainable model for including information about genetic biomarkers and other information that is not routinely collected now. Because wouldn't it be great to know how people across this country did at 1 year out from diagnosis? We don't have a clue today, which is not to discount the efforts of NCCN and so forth. One of the other efforts that we're struggling with, but I think will be very valuable, is having an inventory of our own efforts in the federal government, which ultimately we hope can be linked with private sector efforts, so that we have some sense across an enterprise where additional investments can have the biggest bang for the buck. I mean, the good news about the Cancer Institute is if there's one part of NIH that gets what we do and why it's important and whom we collaborate with all the time, it's NCI. I mean, they are fantastic. In other areas, I would say there's less enthusiasm for what we do. So we'll see how that all shakes out, because obviously the Cancer Institute has got a budget much, much bigger even than the huge numbers we've seen under the Recovery Act. But it is going to be a very important question. And that's why, again, I think the investments in infrastructure are going to be so critically important, because if we can get to a place where the next clinical trial is actually a much smaller increment than launching another brand new one, and all the people and so forth that go with that, because we've already figured out the kind of reusable rocket is the phrase that people use, then we can attack and get to so many important questions.
Okay, this will have to be the last question, unfortunately. Go ahead.
Thanks. I wanted to follow up on get your thoughts on an area that you had mentioned before. My particular area is lung disease, and our society has a registry which we've been starting up on procedures and devices, which I agree are both difficult and challenging. It has to do with both procedures, devices, and registries. In terms of having a sustainable, ongoing registry, a reusable rocket infrastructure to conduct multiple trials, one of the challenges, and I chair that process, is that we do get paid for volume rather than quality, that each institution, while it sounds good in conference, we have to pay the bills, and therefore entering the data, which has a real cost, becomes difficult to sustain outside of a grant. And our goal is to involve community physicians, but clearly there's very little incentive. Even for academic physicians, when we want to share the registry, there's a real big disincentive in that you do the work, they don't, but we all get to use the data, and it has created a governance issue, which we're discussing. So in terms of those dimensions, one was the creation of the infrastructure, the governance, the data sharing in the short to intermediate term, because I really don't think it's going to be an easy to fix problem with some magical EMR. What would be your thoughts on those two areas for devices and for both panelists?
I think we've got a lot of work ahead of us, which is why we're very excited about a recent initiative that just closed about Prospect, which included a strong focus on improving existing registries. I got lots of calls over the holidays that the timeline was too tight on that, and we did manage to extend it till last week. I am expecting a very brisk response, which would be terrific. You're right. Our ideas that electronic medical records will magically solve this are right, but it's way, way early for all the reasons in response to John's earlier question. I think that will be helpful, but I think that you are exactly in the right place already, anticipating and beginning to take head on the issues related to information governance. I actually think that's going to be harder than the technical aspects or even finding the financial support for this work. Who owns these data? Do I have a right to say how it's used? At one point, do you get that kind of informed consent and so forth? So I would commend to you one of our methodological efforts has been developing a guide for registries with the folks from Outcome Science. You talk about broad input. Wow. I never knew what it was to be lobbied till we had a second meeting on the updated guide, and I was hearing from people I hadn't heard from in decades saying, I know I can watch this online, but I really, really want a seat in that room. And so I think these are all issues to be addressed. I actually believe that there's a lot of talk about public-private financing, which is in both health reform bills. I'm not so sure I see the private sector really willing to step up to just contribute to a kitty for research. That has nothing to do with the current economy or anything else. I think it's not how they do business. They make much more earmarked decisions. I am buying this specifically. So I think part of what we're going to need to work out is how do we create a model that allows employers, payers, and others to make those kinds of targeted investments. If I'm an employer and a lot of my people have lung disease, that's going to be in my interest. So how do I work that into my billing system and so forth so that it's an ongoing way to support the research? Not easy to do, and it's not a research problem. It's very much an in-the-weeds kind of issue. But again, the governance issue that you're taking on is so important, so I commend you for that.
Well, on behalf of the Baker Institute and MD Anderson, I want to thank our speakers and I want to thank our audience. This has been an incredibly high-level discussion. And I guess that if I would like to try to quote Churchill, I would say we're not even at the end of the beginning yet. We have a long way to go, but at least we're talking about it and we're trying to point in the right direction. So thanks very much.